We will cover the second line. Really, the world changed completely with CAR T cells. So CAR T cells now are in second line with lysocell and axicell. And then in the recommendation, we propose axicell and lysocell in second line for patients eligible to CAR T cells. So CAR T cells are for patients in relapse and refractory patients, relapse within the first year. And then for the patients that are not eligible for CAR T cells, Glofigemox, or if you are relapsing really late, you may eventually challenge the patients with chemotherapy again and high-dose therapy plus autologous stem cell transplantations.
Welcome to EHA Unplugged, the official podcast channel from the European Hematology Association, EHA. In this episode, we are joined by Professor Maria José Kersten from Amsterdam University Medical Center and by Professor Catherine Thieblemont from the Hospital Saint-Louis in Paris. Together, they will discuss the recently published EHA guideline for the diagnosis, treatment, and follow-up of patients with large B-cell lymphoma, LBCL. They are here to give you an overview of the guidelines and help you navigate the panel's recommendations. Welcome and enjoy this episode.
Hello, I'm Catherine Thieblemont from Paris Saint-Louis Hospital.
Hi, I'm Maria José Kersten. I'm from Amsterdam. We worked together very hard to get this guideline done. We'll discuss all the ins and outs of the guideline.
So this is guidelines about large B-cell lymphomas, and the first step for the workup of the patients is about staging the patients. So how do we stage the patients for large B-cell lymphoma? The first thing is to base the strategies based on the IPI. So we still use this international prognostic index based on 5 factors. So the age of the patients, which is really important, the LDH level, the stage, the number of external sites, and the performance status. And the performance status is really the key to stratify the patients regarding the choice of the treatment that we will administer to the patients and make a choice. So the 3 key factors are age, performance status, and extensions of the disease with the stage, the external sites, and the number of these external sites.
Yeah, and if we go a step back, because of course first we need a diagnosis, so we recommend excision of a lymph node. I think we had a lot of discussion about that. What's your opinion? Should we do needle biopsies or should we excise a whole lymph node?
So there is a different schools for that, and the diagnosis is of course based on this biopsy. Either we choose the surgery or the core needle biopsy. This is really easy to take the second strategy and to have a core needle biopsy. Really easy to get peripheral biopsy, peripheral lymph node biopsy, or profound sites for the biopsy. And this is, I think, better compared to the surgery. Why? Because the surgery will take longer time to get the diagnosis, and sometimes we do not have this time when we treat aggressive disease such as large B-cell lymphomas.
If possible and not too difficult to reach, I think a whole lymph node is probably better, gives you more information on the architecture.
Yes.
Yeah.
And particularly regarding the microenvironment, we know that with the new drugs now, we need to have information regarding the microenvironment. It's always better to have this surgery biopsy, but if it's not possible, of course, a core needle biopsy is really an important step.
And what do you think are the minimal methods that need to be used to get to a diagnosis at this point? Which methods, immunohistochemistry or molecular methods, are really necessary?
Yes, of course. We need to have between high-grade B-cell lymphoma transform from indolent lymphomas, follicular marginal zone lymphomas, primary B-cell lymphomas that are really particular lymphomas. So we need to have immunochemistry. We need to have also FISH diagnosis regarding genes such as MYC, BCL2, BCL6, and to have eventually the subtypes regarding ABC or GCB, which is not now considered as an obligatory marker, because we know that there is no difference in terms of therapeutic strategies between ABCs and GCBs, large B-cell lymphoma.
What do you think of NGS to look at mutational landscape in the tumor cells?
Yes, it's really important and interesting to have these markers, but right now we have no difference in terms of therapeutic strategies based on NGS.
I think that we will see more evidence of targeted agents being more active, for example, in the MCD type.
Yes.
But this is at the moment not, we didn't make it part of the guideline because it's not black and white, and we cannot do this in an evidence-based
Exactly. Maybe in the next round of the guidelines, maybe in the future, in the near future, I'm sure, not right now.
Yeah. And what do you think is the strategy in terms of imaging, diagnosis, and for interim or end of treatment evaluation?
Yes. So as we said at the baseline, it's really important to have a good aspect on the extension of the disease and even the mass, the bulky, and to measure the bulky more than based on the CT scan, but also the PET scan may afford to have a better evaluation of this bulky mass. PET scan at the baseline, and then the PET scan may also be repeated with interim analysis after 2 cycles, 4 cycles, and even at the end of the treatment. So if you are doing interim analysis, you may eventually skip the end of the treatment with PET scan and only do a CT scan. But it's really important to have a sense of the metabolic response assessment, which is really important to know if we have a complete response. Yes. Do you think that there is several aspects to assess this metabolic response in terms of Deauville score?
So at the moment, I think standard is that we use the Deauville score, so the semi-quantitative assessment of the several shades of gray, so to say. I think that for the moment is satisfactory, but I think for interim PET, we might also start implementing the delta SUV, because it has been shown that if at interim PET there is more than 70% decrease in the standardized uptake value, those patients have an especially good prognosis. I don't think that's implemented at the moment at most of the hospitals, but I definitely think delta SUV and at diagnosis the metabolic tumor volume will gain momentum in the coming years.
This effectively is the strategy to evaluate better the patients during the first line. And so, in your opinion, what is the first line treatment for the patients with large B-cell lymphoma? So the common patients, what is the best treatment for large B-cell lymphoma?
Yeah, so it depends, of course, on stage. So for the limited stage patients and low risk factors, I think abbreviated immunochemotherapy is the standard. So mostly 4 cycles of R-CHOP. Maybe we can even go lower with a negative interim PET. But for the stage 2 with bulky disease or stage 3, 4, I remember we had some discussion about what was the best first line. And of course, again, it depends on age, performance status, but also on comorbidities. For example, cardiac comorbidities, which would make treatment with anthracyclines more difficult. But for the standard patients with a low IPI, 0 to 1, I think R-CHOP 6 cycles is still the standard of care for, I don't know, now 25 years or more.
So we know perfectly effectively this first line based on R-CHOP. What about the high-grade B-cell lymphoma? Because we know that R-CHOP is maybe not satisfactory for these patients.
Yeah, so high-grade lymphomas, especially if they are double hit, and as you know now in the new EHA classification, this pertains to patients who have a MYC translocation and BCL2, and it's no longer the MYC and BCL6 or the triple hit. I think there with regular R-CHOP, we don't see good enough outcomes, and also the polar R-CHOP doesn't seem to be better than R-CHOP in that particular population. So there we would go in a fit patient for dose just EPOCH-R or another intensified regimen, and also strongly consider CNS prophylaxis.
What about polar R-CHOP? What is your opinion regarding this treatment, and to whom would like to administer this treatment?
So in the study, the patients with an IPI of 2 to 5 were eligible for this study. So it's a higher risk population. And there was a difference in progression-free survival, so 6% absolute difference, but no difference in overall survival. Probably because we have good salvage options with stem cell transplant or CAR T in the second line. So yeah, it's implemented differently in different countries. For example, in the Netherlands, but I think also in France. Ebola is not reimbursed, so we still give R-CHOP.
And the last question regarding the first line, but we could have a lot of more questions. What about this extranodal disease? Sometimes we have patients with no involvement or few nodal involvement, but extranodal with testes, for example. And we discussed the past few years about CNS prophylaxis. So how could we deal with this CNS prophylaxis and extranodal disease?
I think that's a whole topic on itself. So much discussion about the use of CNS prophylaxis. I think most centers have abandoned intrathecal prophylaxis. So if you think there's an indication for CNS prophylaxis, I would go for high-dose methotrexate, so at least 3 grams per meter square and 2 cycles. And mostly do it at the end of therapy if there's no CNS involvement. And of course, in these patients, you do a baseline CSF assessment. And yeah, so if you look at the extranodal lymphomas, I think it's best demonstrated for primary testicular lymphoma because they have a very high rate of secondary CNS involvement. So we would definitely do it in those patients. I think the indication for CNS prophylaxis has shrunk over the years.
And finally, the last one, because I think is really important, the strategy is really different from the other large B-cell lymphoma, is the primary mediastinal B-cell lymphoma. What is your strategy for this PMBL?
Yeah, so these are mostly young female patients who present with a bulky mediastinal mass. And of course, also here, direct comparison in clinical trials is lacking mostly. But if you look at the results of R-CHOP versus intensified R-CHOP like R-CHOP 14 or dose-adjusted EPOCH-R or other intensified regimens, there's a clear difference in the progression-free survival in those patients. And also very importantly, the rate of complete metabolic remission at the end of the induction. And that's really important because in those patients who still have active disease, you might consider radiation therapy. But these are young female patients and giving them radiation therapy to the chest might also mean an increased risk for breast cancers. I think achieving a CMR is really important. I think the IELSG did a great job in their study demonstrating that in patients with CMR you don't need radiation therapy and that this is achieved much more often with the intensified regimens. It was interesting to see that actually R-CHOP 14 performed more or less the same as even more intensive regimen. So we have we did those just at EPOCH-R, but are drifting back to R-CHOP 14. How about yours?
So this is exactly the same strategy. We know we are using R-CHOP 14. It's really easy. And in this population of patients who are young, R-CHOP 14 is really tolerated and there is no secondary effect, major secondary effect. So yes, we switch to R-CHOP 14 in the primary B-cell lymphoma.
Yeah. And then what do you do in the patients who still have no CMR, so either the Deauville score 4 or 5?
So we calculate, as you said, delta SUV here to be sure that we are really in not a good response. And then we try to biopsy the patients and we go to second line if we are not in complete response.
Yeah. So you wouldn't go for radiation in those patients?
We prefer, depending on how is the residual disease. If you have minimal residual disease with small sites still involved and with hyperfixation, we may eventually propose radiation therapy. But if we have no chemosensitivity, we will move to secondary.
Yeah, I agree. And I think in this study, the IELSG study, they also showed that if you irradiate this Deauville score 4 cases, there's also a very good response. But another strategy is just to wait and repeat the PET scan.
Exactly. this.
Yeah. I think we've covered the first line.
And then we will shortly cover the second line. We had a really a world that changed completely with the CAR T cells. So CAR T cells now are in second line with lysocell and axicell. And then in the recommendation, we propose axicell and lysocell in second line for patients eligible to CAR T cells. And then for the patients that are not eligible for CAR T cells and relapsing, so CAR T cells are for patients in relapse and refractory patients relapse within the first year. And then for the patients that are not eligible for CAR T cells, glofitamab. Or if you are relapsing really late, you may eventually challenge the patients with chemotherapy again and high-dose therapy plus autologous stem cell transplantations. So the choice for the second line is really depending on the time of relapse and the sense of how refractory the disease is regarding chemotherapy.
Yeah, so in different countries, this is weighed a little bit differently by the HTA bodies. For example, in the Netherlands, the patients in the second line who are refractory or who have early relapse should be transplant eligible to receive CAR T, which I think is a little strange because they're not getting high-dose chemotherapy. So they should be eligible for CAR T, I think, and not for stem cell transplant. But hopefully there will be the results of the DAILY 2 study and we can rediscuss this also with our healthcare institute. In France, it's not a problem. You can...
Yes, we can effectively use this strategy for the patients in early relapse. And then the third line, that is really improving with the bispecific antibodies, anti-CD20, anti-CD3, with 2 antibodies available in Europe and almost all over the world with glofitamab and epcoritamab, so both drugs that are changing also the result in third line for patients with refractory disease after 2 prior lines.
Yeah. I think in this context, it's interesting the effort which was done by Florence Brousset. Together with the guidelines, we also actually published a perspective paper in HemaSphere, which was led by Florence, actually looking at the availability of all those new drugs in Europe. She has shown some, I think, more shocking results about clinical trial availability, which is all very different between the different European countries, but also to access in terms of reimbursement to these new drugs, because there are many countries, including ours, where, for example, bispecifics are not yet reimbursed. So we're seeing a completely different picture, even across Europe.
Thank you very much, Marie-José. And thank you to everybody here to have listened to us about these guidelines of large B-cell lymphoma guided by EHA. Thank you very much.
And thank you to the audience for listening. And if you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.